Sure. So my name is Dr. Sierra Richard. I am a women's health and pediatric clinical pharmacist. So what I do is I work in a hospital in an inpatient pharmacy. Currently, I'm an overnight job, so I work 7 days on, 7 days off, 11-hour shifts. So I've really enjoyed that. Being there on overnights, I am the only pharmacist. So it is a lot of responsibility, but also a lot of autonomy. But as a clinical pharmacist, it's a little bit different than what some people think pharmacists do. A lot of people think pharmacists just count pills. I don't remember the last time I counted pills, honestly. That's not something I do on a regular basis. So, what I do on my nights is usually I come in and I get passed off from whoever was there the night before and kind of just jump right in. So I verify medication orders. So every single thing a physician orders or a nurse practitioner or any sort of provider orders comes through pharmacy. And so I look at every single order to make sure everything is correct, everything from the dose to the interval, drug interactions, just all those different things. We also have a pharmacy dosing service where I'm at. So we do medication dosing for patients. So vancomycin, gentamicin, medications that have variable dosing based on renal function and patient weight. Pharmacy goes ahead and handles, and so we'll dose the medication if it's an initial start. And I do a lot of drug level monitoring overnight. So we'll test the drugs, make sure that they're the right concentration in the blood, not going to harm the kidneys or cause any other damage. And we're also getting a concentration that's effective to kill whatever infection we're trying to treat. So those are some other things that I do overnight, as well as just checking whatever medications the technician is making as we verify orders. We also send some stuff up to the floors to stock automated dispensing cabinets, so I check all of that. And probably the biggest part of my job is answering questions. I have a really good relationship with the physician teams that I work with and the nurses as well. And so they call me from everything from, can I run these two medications at the same time through one IV line, to, I have a patient who is COVID-19 positive. Here are the meds that we have tried. What else can we try? Do we have any other options? And sometimes I get really complicated questions about patients who are on a ton of medications. Are there any of these medications that can cause a side effect? So I'll go through a list of 40 medications and see if any of them can cause a specific side effect that the team is concerned about. So in order to be able to do a position like this, I did have to do 6 years of schooling. So I did 2 years of undergraduate studies at Arkansas State University before going to the University of Missouri, Kansas City School of Pharmacy for 4 years. I was at a satellite campus, so I was at the University of Missouri Columbia campus, which was a very interesting experience because there was only 30 of us there. And so after my 4 years of pharmacy school, I did an additional year of residency training in Fort Worth, Texas at Cook Children's Medical Center. And during that year, it was mostly pediatric focused training. And I did everything from staff in the emergency department, work in the inpatient pharmacy, to being up on the NICU floors, PICU floors, PEDS floors, serving as a clinical pharmacist for the team, rounding with the team, and counseling patients and things of that nature. So my patient population varies drastically, and the COVID-19 pandemic has played a big role in that. So normally what our children's or women in children's hospital looks like is I have everything from the babies who are born prematurely at 21 to 23 weeks, all the way up to the mamas who are giving birth. We also do a lot of gynecologic surgeries where I'm at, so post-op patients for gynecology surgeries. So our normal age range is everything from a neonate who's in the neonatal intensive care unit, which is my favorite pediatric unit, all the way up to our gynecologic patients that are usually around 70, 80 years old. So there can be a wide range of patients that I take care of. Thanks to the COVID-19 pandemic, there was a period of time where we were taking overflow from our adult hospital. So one night I got a phone call about a 23-week-old baby. And then I got a phone call right afterwards for a 102-year-old patient and their warfarin dosing. So, you kind of have to be ready for anything in the setting that I'm in. But primarily we have 60 NICU beds, so I do a lot of have a lot of babies, and then we do a lot of women's health patients as well. So a lot of pregnant women. We have a lot of patients who are actively in labor that come in overnight. I feel like that's a lot of my admits overnight are laboring mamas who are coming in, and sometimes they deliver right away, and sometimes they're there for a while. We also get a lot of patients that'll stay with us over the period of time. So that's kind of my patient population. I do like the variability because I have pediatric intensive care unit patients. I have those peds patients. I have patients who are on the NICU. I have moms who are postpartum, and I have those who are, sometimes early on and on bed rest in the hospital for monitoring. So there's a lot of variability in what I get to do, which is really exciting. But during my week, I kind of went, like you said, I kind of went into what I do. But my primary purpose is verifying those medication orders to make as quickly as and safely as possible, because I want to get, of course, the patients their medications, but I want to make sure I'm doing so safely. So I'm really focusing most of my attention on our orders that are coming through and making sure that they're just safe and appropriate for our patients, and making sure I get my calls into the physicians quickly if I have any concerns, because sometimes they're putting in orders in and hoping to get some sleep. So I don't want to have them fall asleep and wake back up, because most of them are on night call whenever they're there. Sometimes they're doing like 24-hour shifts. So I don't want to wake them up. So I'll try to call as quickly as possible so they don't try to go sit down for a nap while they're putting in orders. So those are the biggest things. I think during the night, I also like to do reviews of our women's health patients. We don't currently have somebody to do that during the day shift, and because of our census, we've just not had anybody who's had time to do that. So that's something that if I get the time on nights, I do a clinical chart review of our women's health patients. And what that kind of entails for a pharmacist is really focusing in on that medication therapy and giving another set of eyes. I work with awesome physicians, but they are humans, and it's easy to overlook things. So what I like to do is I go in and I look and say, okay, what are this patient's home meds? Are they currently on those home meds? Should they be on their home medications? I look at their medication list inpatient to make sure that everything looks appropriate, all of our doses are correct, everything is still necessary. These moms move very fast, so they were sometimes needing antibiotics because they were waiting to deliver and we were trying to prevent an infection for the baby. But once they've had the baby, they no longer need those antibiotics. So making sure everything gets discontinued when it should, making sure that we are monitoring everything appropriately. If there's drugs that need drug levels, that those are being drawn. Those are probably the biggest things that I'm concerned about with my women's health patients, but just then going through all of their medications, making sure that every indication that needs a medication has one on board, that the medications we're currently on are working. We have a lot of patients who have preeclampsia, so are we on the most appropriate dose of those blood pressure medications? Should we change those? And then I also look and prep for discharge. A lot of times I can see, okay, this patient's probably going to discharge in the morning, and see what we have on board and make sure they're going home on the correct medication as well. So my journey to women's health has been a little interesting. So as far as the journey for pharmacy school, most schools require some sort of prerequisites, whether you're doing that as there are some early commit programs, which you still have to do those prerequisites to actually get into the program officially. So usually that lasts 2 to 3 years, depending on the program and what the requirements were. I thought that was hard. I was wrong. That was not the hard part of the journey at all. I look back, I was like, wow, that was so not hard compared to what pharmacy school was. Pharmacy school is definitely difficult. I did a lot of things at pharmacy school. I was very busy. I was very active in organizations. So the American Pharmacists Association Academy Student Pharmacist in particular. I served in a regional office before I was done. I served at the national level as a committee member, as the student representative on the governmental affairs committee. So those were like things that I was doing outside of school, which made the school part harder. On top of that, I was also working as an intern, which is something that's pretty common for pharmacy students, is to intern throughout your 4 years of pharmacy school to get some job experience. And the cool thing is that was a great move for me because I'm currently working at the hospital I interned at. So I went out and got a job and got to come back there. So that was really exciting. But it comes down to just learning how to manage your time. And I did a lot of things that I think really did help me. So having that job helped, having that leadership experience helped. I also gained a lot of friends through that and being able to meet them at organizations. Some of my best friends came from other schools across the country that I got to meet through those experiences. But pharmacy school was definitely difficult. There were times where it was harder than others. I think the first semester was really hard, that transition from undergrad to pharmacy school. And then the second year of pharmacy school was incredibly difficult. That's when you start really diving in. We had the heaviest class load. The third year kind of backs off a little bit and you start getting to put everything together. At least that's how it was for me. So that's when you start taking classes where they're like, okay, we've taught you all of this knowledge. Now we're going to learn how to apply it to a patient. And that's when we first really started seeing patients. And then that last year was all clinical rotations where you were seeing patients in different settings. So you do everything from a retail pharmacy. I was with Walmart when I did that. And then everything in between. I did psychiatry, I did cardiology, I did neonatal intensive care unit. I just felt like I was going all over the place, ambulatory care at the VA. So it was just a wide variety of experiences, which gave me a better idea of where I did want to specialize, which ended up being pediatrics. I really loved my interning job, having the women's health and pediatrics. I would say pharmacy is just now dipping its toes into women's health. Previously, there was this misconception that this population of patients maybe didn't need as much pharmacist intervention because they were young and normally healthy women coming in to give birth, but we have learned that that's not the case. And there's really starting to become an emphasis, even from our government, on the high morbidity and mortality. We also have better technology to allow women to freeze their eggs and possibly deliver at a later time in life. And so those changes and seeing more women getting pregnant and giving birth later on in life has increased the number of medications that are often used in that setting. So for me, really starting with the women's health was because when I stepped into this job, that was where the need was at my workplace. There's people who were able to take care of those pediatric patients during the day, but nobody was really designated to women's health. And that was something I did miss in residency. I loved the peds patients. I loved pediatrics, especially the NICU. Like I said before, that's an area I just really love. But I did miss taking care of those women's health patients because there's something really awesome about getting to take care of the mother who is delivering, all the way from whenever she walks in the door in labor or maybe to be induced, all the way through until she is walking out the door, hopefully with her baby. And also getting to take care of baby, which is the other cool part of nights because I'm the pharmacist. So if there is any concerns with baby, I'm taking care of those things as well. So getting to take care of both mom and baby and being a part of that initial stage of life is really, really cool. And so I got into it basically out of need, but also because I really enjoyed it, kind of wanted to step into that role. And it was something I was passionate about. So that's kind of how I ended up in women's health. With pharmacy, I have noticed, yes, there are opportunities to specialize, but specializing in other areas is possible. It's just being willing to take opportunities where they come, which where mine was just a set of needs that was in my hospital setting. So my story's kind of funny looking back. This was before BuzzFeed. That's gonna age me a little bit, but we had to take these quizzes in school about what you're gonna be when you grow up. And so what skills do you have that would make you good at certain things? And so I had to take one of those. It was similar to a BuzzFeed quiz, but not the same thing for school. And I got pharmacist. So I I guess this was a good thing. I told my mom that I got that. Well, pharmacist is what it says I was going to be, and I don't even remember what else it said was a possibility, but pharmacist was number one. And so my mom took it upon herself, because she knew that I needed a summer job, to tell the local pharmacists that I got pharmacist as my top career choice on this quiz. And he was like, "Oh, well, I need somebody to help for the summer because we have people taking vacations the whole time. Like, have her come in and I'll interview her and maybe we can get her in here for the summer." So the next day I went and interviewed for a job at the local retail pharmacy. I was 16 at the time. The state of Missouri doesn't have age limitations for pharmacy technicians. So next thing I know, I was applying for a pharmacy technician license. And in a couple months, I started working as a summer technician, just like part-time, depending on the week. Some weeks I was working full-time to help cover vacation time and whatnot, but I got my start there and I really, really enjoyed it. I knew that I had liked chemistry from early on and was more a chemistry fan than a biology fan. I actually competed in the International Science Fair in my senior year in the chemistry section. So chemistry was kind of my thing in high school. And when I had seen the opportunities for a pharmacist to also teach, that was very important to me. So I really, really love to teach. And for the longest time, I thought I was going to be a teacher, but I found so much teaching in pharmacy, not just teaching patients, but also teaching other healthcare providers, teaching students as well. So there's just so many opportunities to teach others in pharmacy that it kind of combined a lot of my loves, that chemistry love, that teaching love. And then I just really enjoyed learning how the medications worked and how they interacted with each other. And so I just found kind of my home there. So when I graduated pharmacy school, I kind of was on that same path all the way through. I knew when I went to undergrad that is my ultimate goal, was to go to pharmacy school. So I set myself up in undergrad to do the prerequisites required for the school I wanted to go to, which was UMKC, and kind of went from there. So that's how I got into being a pharmacist. I've wanted to be a pharmacist since I was 16, and there were moments where you kind of were like, oh, that was cool, you know, maybe I want to do this. And I looked at other things. I did keep my options open, but every time I came back to pharmacy. So that's where I ended up, and I'm very happy that I did it. Well, COVID-19 was quite the obstacle itself. Um, you know, there was always moments where I struggled in pharmacy school here and there. So my first one was I failed my first exam in pharmacy school. Granted, I found out later that 70% of the class also failed that test. I think it's kind of the wake-up call test. I did very well in the class by the end of it, but you kind of walk in, and I studied like I did in undergrad, and that just wasn't going to cut it in pharmacy school. And I learned that very quickly. It's the only test I failed. But that kind of kicked my butt in gear, and I was like, okay, what do I have to do to pass in pharmacy school? So I reached out to the professor. We got into study groups. I learned how to study better. I asked my mentor, we were assigned a mentor in pharmacy school. I met with him and he gave me some tips. And really, every time I've hit an obstacle, I've reached out to the network of people to help me. I don't think it matters what area of medicine you want to go to. That network of people that are there to support you, whether it's family, whether it's mentors in pharmacy, or whatever profession you're going into, those people are so important when you get stuck. And so the same thing kind of happened to me when I was looking for a job with the COVID-19 situation. I had originally planned to do a fellowship this year. And unfortunately, because of COVID-19, the fellowship they decided to pull the funding just in case, because there was so much uncertainty. So I thought I had a fellowship. The fellowship disappeared in April, and I'm left without a job. And I'm married, and I'm like, what am I going to do? This fellowship was like back where my husband was. I spent my year of residency apart from my husband. He was in Missouri, I was in Texas. So I'm like, oh my gosh, what am I going to do? And so I reached out to the network of people that I knew, and it just so happened that there was a pharmacist on nights that was retiring where I used to work. Um, and I had to be patient. I actually interviewed for my current job on my last day of residency. I moved back from Texas, just like hoping this job worked out. Um, and it did, but I think a lot of that had to do with, again, I reached out to the people back home. Hey, do you know of anything? Because even if it wasn't at that hospital that I wanted to end up at where I'm at, I was reaching out to people from this area that I knew that were pharmacists who could help me find a position. And that, I think, is really how I've overcome any of the challenges that I've had, is just reaching out to that network of people who support me, who have went through these things before and can really help. This is an area that some people like to point fingers, is like, your job as a pharmacist is going to go away for artificial intelligence. People say that a lot about pharmacy. And I think it's typically coming from people who have not worked with our artificial intelligence that we have now, and also don't understand what we're really doing as pharmacists. So currently we have a lot of technology that helps us do our job. I will be honest. We have these flags that'll pop up on our electronic medical records when we're verifying orders. It's like, hey, these medications interact. But I would probably say 8 out of 10 of my prescriptions that I'm verifying have a flag. And I would say maybe 1 out of 10 is actually relevant to the patient. So we have all of this technology that can run data, but it cannot run patients. And that's kind of where we're at right now, is, okay, yes, we're on 2 medications that both can cause this patient to be drowsy, but the patient is intubated. So that doesn't really matter if the patient is drowsy. They're sedated anyway. So it's fine that this drug is going to make them drowsy. Doesn't matter in this case. And then, we can also look at that and say, yes, this is a actual drug interaction that I'm concerned about. We also have dosing range monitors. Well, those can be helpful, but those just do the typical range, but I frequently have patients that are not typical. I also work with pediatric patients, and a lot of this technology does not apply to pediatrics. I also work with pregnant women. A lot of this data does not work on pregnant women. So, a lot of the stuff that we have works on your standard patient, and they can be very helpful in that situation. But a lot of it doesn't apply to these special populations, the really old, the really young, our pregnant patients. They kind of fall out of those categories. And so I shift through a lot of this information that technology and artificial intelligence gives us and figure out what's relevant for the patient. Does it help me do my job? Yes. Do I think in the next even 5 to 10 years it will be able to take my job? No. I mean, we're barely at the point that it can give me only the relevant information that I need. It can identify certain things that are important for patients. So a lot of times I'm the one who's catching this renal dysfunction. I'm the one who's catching liver dysfunction, or I'm the one who's catching that a home med wasn't restarted, because that's not always appropriate, but sometimes it is. So there's, several things that these computers, I think, will continue to help us do better, but I don't see in the next few years it actually completely taking over our jobs. I think some of the things that it will hopefully get better at is helping us possibly with figuring out medication options for patients. We are all human. There's no way for us to know all the guidelines. And I know there's a lot of technology that they're looking at helping with diagnostics or treatment algorithms. And once again, I think those will be helpful, but I don't think that they will ever take away the personal side of it, because every patient is different. Also, what we have available is different. Just because this is the best treatment option doesn't mean that we have it available. Medications right now are on shortage. We've had to deal with a lot of that due to the pandemic. And even before that, we've been dealing with drug shortages. So just because it's the best option doesn't mean it's the option we have. So what are the other options and what's going to be best for the patient? All of that comes into a team based approach where you have pharmacy and the physicians and the nurses and the nurse practitioners and respiratory therapy and whoever else is on the team coming together to make a decision about what's best for the patient. Get as much experience as possible and just keep your options open. I think I did shadowings for physicians. I did shadowing for several other professions in healthcare. And I think that only made me a better pharmacist, because from that shadowing, I had a better idea of what those other healthcare professionals do. And I think one of the most beneficial days I had in pharmacy school is I spent the entire day with a nurse, and she explained how she looks at medications. And so it makes me a better pharmacist because I know what lens that nurse is looking through when she thinks about medications. So I can talk to her at that same level of in that with that lens on. So I can hopefully have better communication and end up having better outcomes for patients whenever I get calls from them. I think, you know, healthcare is a team sport. I like to say that a lot because none of us can do what we do the best that we can by ourselves. I work with tons and tons and tons of healthcare professionals. Every single night I get calls from a wide variety of people about medications. Just the other day, I spent 30 minutes on the phone with a physician, and we were trying to sort out the patient's home medications with the patient on the phone. And we were sitting there, and it was a team event. We had the nurse, we had the physician, we had the patient, we had me with pharmacy, and we were all working to make sure that their medications from home were all sorted out when they were here. That is my biggest piece of advice, is just be open to other healthcare professions, whether you're doing that because you don't know what you want to do and you want to sort things out, or if you know for sure what you want to do, find out what the people on your team are going to do, because I think that makes you a better practitioner. And just be willing to work with others and take as many opportunities as you can to shadow, or, you know, work in a pharmacy, work in a lab, work as, you know, a patient aide, whatever you can do to see what it's like to work in healthcare. I think every little bit of that helps and will make you a better healthcare practitioner later on.